How's things? It's John. I'm here with the Quest Adventure video racing series, and today we're going to go on about knee pain in the front of the knee, kind of like behind the kneecap. Nasty stuff. Let's go. Right, so let's just quickly go over the main 3 reasons why you might get pain at the front of your knee. First one, overload. You've gone and doubled your normal run volume in 1 week because you felt like He-Man. It's not a good idea. It can cause this problem. 2, you've got some weakness up around the chain. So you got the hip muscles, the quads, hamstrings. That can be enough of a reason to increase the force going through the knee and give you pain. 3, your ankle is stiff. I've seen it a few times in the clinic. Someone's gone over their ankle a year ago, they never quite got their full movement back, and that'll change your running dynamics, which can give you pain. And 4, your actual running technique. Are you taking huge steps and that will increase forces through to the knee? Right, well, you can get a couple of types of different front knee pain, but we're going to talk about the one that's underneath the kneecap. So this is how one of the ways of diagnosing it is to press on the top of your kneecap. Any discomfort? No. The sides? Maybe on the inside commonly, and maybe at the bottom. So if I press the lower part of my kneecap and we get pain, then that's what we call patellofemoral pain, or pain underneath the kneecap. What we're not going to discuss today is the tendon here, the patella tendon, the rope-like structure, and that is treated differently to the patellofemoral pain under the kneecap. Right, well, the first thing you want to do is allow the symptoms to settle. This means look at your load and manage it correctly. Reduce the load by half, try that. Has that helped? If not, 3/4. Then I'd suggest taking some anti-inflammatories. Ask your pharmacist. My wife would bust my balls if I didn't put that in. And that'll help settle down that inflammation or irritation underneath the kneecap. So we mentioned the hip muscles. I like to check this test. It's just to see if there's obvious poor glute activation. Okay, so we get the patient to lie in their tummy. And then with permission, I'll ask to put my hand on the buttock and the thigh. And then we ask them to lift the left leg up off the bed. You should get glute activation within 10 degrees of the leg lifting. But I've seen patients who have knee pain and other issues where they'll lift the leg and there is no glute activation. It's all coming from the hamstring. Problem. 3rd, check the strength of the muscles. We can do this by the glute med, which is a leg back, up, and turned up this way. And then I will press on this area, and the patient has to resist. If there's obvious weakness between affected and unaffected leg, then that has to be addressed too. Remember the ankle. Is it stiff? Check it. Put the foot a distance from the wall. Go for the wall with your knee, but keep the heel down. Compare with the other side. If there's a big difference, maybe 50% less, and you can't get through, and this is the side that has the sore knee, then you need to get that ankle mobilized first to have any chance in kind of helping that knee. Physiotherapy will help with that. And finally, look at the way you move. With your running, if you're taking massive mammoth steps, there's a really strong link between this and anterior knee pain, or pain at the front of the knee. And so just take smaller strides, and that will help the situation. And also look to see if you're crossing your feet over. So have an imaginary line and keep left and right separate side of the line. So that's it for today's video on knee pain, right? Next week I want to do something on the importance of hip mobility. It's going to be maybe a longer video because I want to take you through some nice hip mobilizing exercises to keep that joint free, because with a lot of cycling it can get kind of stiff, and I'm a good example of that, so you'll see next week. Stay tuned, hope you're enjoying it. Ciao.